It's time for another warm-up review. Let's get going. Which drug category has each of the following endings? So we have dronate, that's going to be the bisphosphonates like alendronate. We have chol, that's going to be the cholinergic agonist like bethanechol. Mustine, that's going to be ending for the nitrosoureas, for example, carmustine. Statin are going to be the HMG-CoA reductase inhibitors like atorvastatin. Then bendazole is going to be endings for the group of the antihelminthic drugs like mebendazole. Next question. What are the side effects of amiodarone? So remember with amiodarone, you've got to monitor the PFTs, the LFTs, and the TFTs because amiodarone can cause pulmonary fibrosis. It can be hepatotoxic, and it can cause either hypo or hyperthyroidism. It can also cause some corneal deposits, photosensitivity, neurologic effects, constipation, and cardiovascular effects. So a lot of different side effects there. Next, what conditions are associated with diastolic murmurs? So diastolic murmurs are almost always abnormal, and they can be seen with mitral stenosis, tricuspid stenosis, aortic regurg, and pulmonic regurg. All right, that brings us to the end of the warm-up. Let's get to that lecture.
In this video, we're going to talk about some assorted musculoskeletal injuries and joint problems, things like ankle sprains and tennis elbow. You'll probably see a few of these over the course of your exam. We're going to start in the hand, work our way up to the shoulder, and then go from the hips down to the feet. But first, one tiny little high-yield fact that's worth noting is that joints represent a potential space, and these joint spaces have a negative hydrostatic pressure, around -3 to -5 millimeters mercury. So in the same way that your pericardial cavity and your pleural cavity are potential spaces that have negative hydrostatic pressure that draws fluid into them, your joints also have a negative pressure. So let's review some anatomy. You definitely need to be able to identify the bones of the wrist, the carpal bones. Now there are lots of mnemonic for these, but one good one is so long to pinky, here comes the thumb, which is nice because pinky and thumb match up with the side of the hand those fingers are found on.
So starting with the proximal row of bones, so long to pinky stands for scaphoid, lunate, triquetrum, and pisiform. And then here comes the thumb goes back the other way toward the thumb. Hamate, capitate, trapezoid, and trapezium. And if you have trouble remembering which of those is closest to the thumb, just remember the thumb swings on the trapeze, like the trapezium.
When you punch something, or punch someone, with a clenched fist and you have tenderness in the anatomical snuff box, which carpal bone is most likely fractured? That's a scaphoid fracture. Even if the initial x-ray is negative for an obvious fracture, if there's tenderness in the anatomical snuff box, you have to presume that there's a scaphoid fracture. And the reason it's dangerous to miss a scaphoid fracture, especially one that you can't see right away on x-ray, is that blood is supplied to the scaphoid bone from distal to proximal. So if a scaphoid fracture cuts off that blood flow and you don't catch it and fix it, that can result in avascular necrosis of the proximal fragment, which can result in a painful arthritis. Let's move up to the elbow. I want to briefly discuss epicondylitis, which is inflammation of one of the epicondyles of the elbow. There's lateral epicondylitis, which is called tennis elbow. This is inflammation of the lateral epicondyle due to repetitive use that leads to small tears in the wrist extensor tendons that attach here. So it may be a little more accurate to call this a tendinopathy rather than epicondylitis. And then medial epicondylitis is injury to the medial epicondyle and the wrist flexors, and that's called golfer's elbow. Now a student sent us a pretty good mnemonic. In golf, you aim for the middle of the fairway, the medial part of the course. And in tennis, you aim for the lateral edges of the tennis court. So golfer's elbow affects the medial epicondyle, and tennis elbow affects the lateral epicondyle. If you move just a little north of the elbow, you're going to find the biceps tendon. So let me say a word about rupture of the biceps tendon. How would a ruptured biceps tendon present? Well, the biceps tendon can tear either at the elbow or at the shoulder, and it usually occurs in relation to lifting something heavy. So first you're going to see a lot of bruising in the area, and then eventually you're going to see a muscle bulge in the mid part of the upper arm as the muscle contracts. And you might think, that looks terrible, we really need to go in and fix that. But you don't always need to fix it. If the patient's an older patient and is able to function and recover just fine, there's nothing else you have to do about it. So we don't always surgically repair a torn biceps. But if it's a young patient or if it's limiting them functionally, surgical repair is an option. This is sometimes called a Popeye lesion, which doesn't make a lot of sense to me since Popeye has big bulging forearms and not big biceps. But at least the name is memorable. And while we're talking about tendon rupture, What class of antibiotics can increase the risk of tendinopathy and tendon rupture in adults? Fluoroquinolones. They don't really increase the risk of biceps tendon rupture, but Achilles tendon rupture is certainly a known complication. It's extremely rare, but it's still worth knowing. Now let's turn our attention to the shoulder, starting with the muscles of the rotator cuff. So what are the 4 rotator cuff muscles? They're the supraspinatus, the infraspinatus, the teres minor, and the subscapularis, which spells sits. And we use a lowercase t to remind you that this is not the teres major, it's the teres minor. Now the rotator cuff is a 3 or 4 star topic, so make sure you know those muscles. Now, which rotator cuff muscle initiates abduction of the arm, the first 10 or 15 degrees? That's the supraspinatus muscle. And the way you test for a supraspinatus injury is with an empty can test. So make sure you know this. You have the patient abduct the arm to 90 degrees, and then about 30 degrees of forward flexion, and then you try to pronate the forearm until the thumb is pointed straight down, like they're emptying a can or pouring out a 40. And you try to press the arm back down while the patient tries to resist you. And if there's pain and weakness at the same time, that suggests a supraspinatus injury. Now, which 2 rotator cuff muscles rotate the arm laterally or externally? That's the infraspinatus and the teres minor. Those are the lateral rotators of the shoulder. And then the medial or internal rotator is the subscapularis. Next, let's talk about shoulder dislocation and shoulder separation. Now, there's a question in the study guide that says, what's the difference between a dislocated shoulder and a separated shoulder? And they're very different in terms of which structures are involved. They only sound similar. In a dislocated shoulder, the head of the humerus rotates out of the glenoid cavity. But in a separated shoulder, it's the clavicle that's separating from the acromion process and the coracoid process of the scapula. Then the next question says, what structures can be damaged in an anterior shoulder dislocation? This question in and of itself is probably about 3 stars. With an anterior shoulder dislocation, you can have injury to the axillary nerve and the posterior circumflex artery, an injury to the supraspinatus tendon that we were just talking about with shoulder impingement. You can also injure the anterior glenohumeral ligaments, and then you get some separation of the glenoid labrum from the articular surface of the anterior glenoid neck. That's called a Bankart lesion. Or you could have a traumatic defect of the posterolateral humeral head due to forceful impact against the anterior rim of the glenoid. And that's referred to as a Hill-Sachs lesion. So on the left, you see that the shoulder has become dislocated and the head of the humerus impacts the glenoid rim. And then on the right, after the dislocation has been reduced, you see this prominent vertical white line where that impact fractured the head of the humerus. That's the Hill-Sachs lesion, or the Hill-Sachs fracture. And how do we test for axillary nerve damage in an anterior shoulder dislocation? You test for sensation. You can lightly touch the deltoid region and ask if the patient can feel it. If they can't feel it, that could indicate an axillary nerve injury. So check that before you reduce the dislocated shoulder, so you know if the axillary nerve was injured before the reduction. And then you also want to check after reduction to document whether or not it was injured after the reduction. Now, whenever you put a bone back into place, that's called a reduction. If you do that without having to do surgery, that's called a closed reduction. If you surgically put a bone back into place, that's called an open reduction. And maybe you've heard the term ORIF, which is an open reduction internal fixation. That's where you not only do surgery to put the bone back into place, but you also fix it in place with a screw or a plate or a pin. So it's an open reduction with internal fixation. That's most commonly seen in fractures rather than dislocations. And speaking of fractures, and before we move from the upper extremity to the lower extremity, I want to mention a couple of types of fractures that we see in children, especially in the forearm. A green stick fracture occurs when a long bone is bent so that the cortex on one side is fractured, but the cortex on the opposite side of the bone doesn't fracture, but it kind of bends. This occurs because the bone is still immature and still relatively soft and pliable. So you see these incomplete fractures like you're trying to break a green branch from a tree and it doesn't break all the way through. And then another type of incomplete fracture is called a torus fracture or a buccal fracture. This can happen when a force is applied to the end of an immature long bone, along the longitudinal axis of the bone, and the cortex kind of buckles. So you see the subtle bowing or buckling of the cortex. And these are relatively stable, so you just have to cast them to immobilize them. Now we're ready to move from the upper extremity to the lower extremity. So the question in the study guide says, what is the most common type of hip dislocation and what structures can be damaged with this type of dislocation? So by far the most common type of hip dislocation is a posterior dislocation, where the femoral head slips out of the acetabulum posteriorly. About 90% of hip dislocations are posterior dislocations. So one of the classic injuries where this can happen is a motor vehicle accident where the knee strikes the dashboard with the thigh slightly abducted, and that drives the femoral head posteriorly, so you get a posterior hip dislocation. And then the structures that could be damaged with a posterior hip dislocation include the medial and lateral circumflex femoral arteries, both of which branch off the deep femoral artery, and they form a ring around the upper part of the femur, just below the greater trochanter. This ring supplies blood to the femoral neck, and you can imagine that if the hip is dislocated, it might tug on that arterial ring and cause a vascular injury. Posterior hip dislocations can also injure the femoral vein and the sciatic nerve and the head of the femur itself. Moving from the hip to the knee, let's talk about prepatellar bursitis. A bursa is a sac of tissue that contains synovial fluid, and these bursae form cushions between bones and tendons, or between bones and muscles, to reduce friction as our joints move. And if a bursa gets inflamed, that's called bursitis. Now, there's a bursa in front of the patella, the kneecap, and it's called the prepatellar bursa. And if you spend a lot of time kneeling, or you have other repetitive trauma to the anterior patella, this bursa can get inflamed and you'll have prepatellar bursitis. This is also called housemaid's knee, because you can imagine old school cleaning women spending a lot of time on their knees scrubbing floors. Another common type of traumatic knee injury is called the unhappy triad, or the terrible triad, or O'Donoghue's triad. Now, this is generally a sports injury that occurs due to force applied to the lateral aspect of the knee while the foot is planted, kind of like being tackled from the side. In an unhappy triad injury, there are two structures that will definitely be injured: the medial collateral ligament and the anterior cruciate ligament. Then the third part of the unhappy triad is going to be either the lateral meniscus, which is injured about 56% of the time, or the medial meniscus, which is injured about 44% of the time. Now, that seems simple enough, right? MCL, ACL, and a tear of either the lateral or medial meniscus. Unfortunately, the medical literature is an absolute jungle of contradictory, authoritative statements about which meniscus should be included in the unhappy triad. When Dr. O'Donoghue described this triad back in 1950, he included the medial meniscus. So for about 40 years, that's what doctors learned. But then around 1990, that classic triad was called into question, and some studies began to show that in fact the lateral meniscus was more commonly injured. Like I said, it's about 56% lateral to 44% medial. I'm no statistician, but that's pretty close to 50-50 if you ask me. But some experts insist that we should honor Dr. O'Donoghue's original description by using the classic unhappy triad name to describe medial meniscus injuries. And then other experts say that if the lateral meniscus tears are more common, we should redefine the unhappy triad terminology. Now, you're not likely to be asked, what are the three components of the unhappy triad of the knee? And you're going to have to choose between the medial or lateral meniscus. But they might give you a patient with an ACL and an MCL injury and then say which other structure is most likely to be injured in this patient. And you just need to remember that the lateral meniscus injury is slightly more common. So here's how I remember it. Lateral starts with L, medial starts with M. L and M are both really close together in the alphabet, so you know it's almost 50-50. So which one comes first? L comes before M. So lateral meniscus tears are slightly more common in unhappy triad injuries than medial meniscus tears. Now, while we're talking about the knee, let's talk about some tests you might do while you're examining the knee to identify torn ligaments or a torn meniscus. Now, this is really more step 2 material, so I'm going to go through these kind of quickly. The McMurray test is a test for a torn meniscus. So you flex the knee to 90 degrees, then you grab the heel and either externally rotate the tibia or internally rotate the tibia. And then while you maintain that rotation, you slowly extend the knee and flex the knee, kind of going back and forth. And you're looking for either pain or a popping sensation. If there's pain and popping during internal rotation, that's probably due to a torn lateral meniscus. If there's pain and popping during external rotation, that should make you think of a torn medial meniscus. The pain is opposite the side of the rotation. To test for a torn ACL, you're going to do the anterior drawer test. This is where you flex the patient's knee to 90 degrees and you pull the tibia anteriorly, kind of like you're pulling a drawer open. And if the tibia moves farther anteriorly than it should, that's called an anterior drawer sign, or a positive anterior drawer test. There's also something called the Lockman test, which is the same thing except you put the knee at about 30 degrees of flexion instead of 90 degrees. Now, beyond physical exam, the best imaging study to diagnose a torn ACL is an MRI of the knee. That has been known to pop up on step 1. So this is an MRI of a normal, intact ACL. This is a lateral view of the knee, and here's the femur, and the tibia, and the patella. And the ACL runs from the back of the femur toward the front of the tibia. So a normal ACL will show up as a prominent dark line. Now, when there's an acute ACL tear, you lose that clear line. In an acute tear, there's hemorrhage and edema, so everything looks hazy and indistinct. Over time, when that acute inflammation has settled down, you might be able to make out the short, retracted ends of the ligament, like this. So again, the anterior drawer test is testing for an ACL injury. There's also a posterior drawer test, which is where you put the knee at 90 degrees again, and you push the tibia posteriorly. And if it slides too far back, that suggests a PCL tear. And then to test for an MCL or LCL tear, you extend the knee again, and you either apply a lateral force or a medial force. And you're looking to see if the joint space widens, which would suggest either an MCL tear or an LCL tear, depending on which side of the knee is unstable. So these are tests for abnormal passive abduction or abnormal passive adduction. And then one last knee pathology you might pick up on exam is a Baker's cyst, which is a collection of synovial fluid in the popliteal fossa behind the knee. So this is seen in patients who have chronic knee arthritis, and it's basically an abnormal extension of the synovial space posteriorly. And finally, we come to the ankle. So let's talk briefly about ankle sprains. A sprain is basically where you stretch a ligament too far and it tears a little bit on a microscopic level, sort of a partial rupture of the ligament. Now, most ankle sprains occur laterally, like if you roll your ankle. It's very difficult to sprain your ankle immediately because the ankle just doesn't bend that way. But it's pretty easily to invert your foot and then step down and put your body weight on it, and you tear up your lateral ankle ligaments that way. There are actually 3 ligaments that hold the bones together. There's the anterior talofibular ligament, and that's the most commonly injured ligament in an ankle sprain. A student sent us a mnemonic which is to abbreviate the anterior talofibular ligament as the ATF ligament, and that stands for always tears first. So the most common ligament injured in an ankle sprain is the anterior talofibular ligament. There's also the calcaneofibular ligament, and there's the posterior talofibular ligament. And they're usually injured in that order. So the more severe the ankle sprain, the farther down you go in this list. And then on the medial side, there's the deltoid ligament holding your ankle together. And it's very rare to injure that one. Now in the study guide it asks, how should an ankle sprain be treated? And the mnemonic is RICE. Rest, ice, compression, and elevation. You have the patient rest the foot by using crutches until they're able to bear weight and walk with a normal gait. They never do that, but that's the recommendation. Ice or cold packs for about 20 minutes every 2 hours for the first 48 hours. Compression with an ACE bandage, and then elevation of the foot above the level of the heart whenever possible to help reduce swelling. So propping the foot up, even if it's not above the heart, will help reduce the effect of gravity and pulling fluid into the area and causing more swelling. NSAIDs are also helpful in the first 48 hours, and then range of motion exercises like picking up marbles with the toes or tracing the alphabet in the air with the big toe or making circles with the foot. Those can all be helpful exercises. So now it's time for the end of session quiz. So pause the video and answer those questions, then we'll go through them together. First question, which muscles of the rotator cuff are responsible for each of the following actions? So the initial 15 degrees of arm abduction is the supraspinatus. External rotation of the arm is the infraspinatus and the teres minor. And internal rotation of the arm is the subscapularis. Next, which antibiotic class is known to increase the risk of tendon rupture in adults? Fluoroquinolones. And the last question, which ligaments are typically injured during an ankle sprain? Remember, it's the lateral ligaments of the ankle. Always tears first is the anterior talofibular ligament. That's the most common. But with a severe sprain, you could also see injury to the calcaneofibular ligament and the posterior talofibular ligament. Then we have just a couple of rapid fire facts. Positive anterior drawer sign should make you think of an ACL injury, and tenderness in the anatomical snuff box should make you think of a scaphoid fracture. That's it for now. I'll see you next time. Shall we dance?
You know I'm not getting your cut.
You just want to see me. Hello, I'm Dr. Mike McInnis with a medical news flash. For years, the O'Donoghue triad, also known as the unhappy triad or the terrible triad, consisted of injury to the ACL, the MCL, and the medial meniscus.
Oh, my ACL, my MCL, my medial meniscus. Oh, it's so terrible. I'm so unhappy. Oh.
But more recent studies show that a little more than half of these so-called O'Donoghue's triad injuries involve the ACL, the MCL, and the lateral meniscus.
Oh, my ACL, my MCL, my lateral meniscus. Oh, it's so terrible. I'm so very unhappy.
And that's your medical news flash.